The proctoring is another term that is used, and it is a different type of mentoring in a way, but we just wanted to understand, to add it to the agenda so that people understand the differences between proctoring and mentoring, and to also understand what's the SCTS position on proctoring. So Steve Billing has authored this document, I understand, and he's going to talk us through it. Thanks very much, Steve.
Mahmoud, thank you very much for the invitation to speak to this today. Proctoring is increasingly becoming an important issue in cardiothoracic practice, and as you allude, it is different from mentoring, although there can be some overlapping themes. I suspect I was invited to speak on this since I co-authored or co-drafted the guideline for the SCTS with Steve Woolley. And of course, I've been a proctoree, if that's the correct term, in the past, and I've seen other issues of proctoring from the outside. So I'll try and give you my take on this. Now, firstly, the boring details. If you Google proctoring, you'll see that in North America, this is the process whereby an institution confirms the competence of any newly appointed staff member. And similarly in North America, the process of mentoring or supervision of a new procedure is called preceptorship. Whereas I think we would all agree that in the UK, we understand proctoring to be a process of mentoring, training, and supervision in a new procedure. And this is because medical practice has changed. We now know that Paget was wrong. And anybody of my generation or before would probably have done house jobs in which this is how the ward round looked. My house officer ward round looked very much like this, but I don't think anybody would now feel that see one, do one, teach one is good enough. So we need progress in surgery, and the issue arises because some of the newer techniques will not have been taught to people while they were trainees, and new techniques may need to be learned and adopted by the consultant team. So we would all agree that we want to advance surgical treatment for our patients. And I think we'd also agree that we want to minimize the surgical trauma and insult involved. However, I don't think we could justify any increased risk being faced by any patient, either because of surgeon, institution, or technique issues. So we need safe transmission of surgical advances, and that's where proctoring comes in. And we need a process of governance rather than competition to improve. And while this kind of competition was seen as very glamorous in 1970, I don't think it would be seen as acceptable today. So just for the mentors here, this is what mentor looks like. The guy on the left, I'm afraid, Mahmoud, you're going to need to bleach your hair and get a little headband. Mentor was actually the son of Alcimus, who was one of Achilles' companions. And when Odysseus went off to war, he left his son Telemachus in the care of Mentor, and I believe that's where the term comes from. Proctor has a much less interesting history. This is procurator, meaning an official, a manager, or a supervisor. And as you mentioned, there is now an SCTS document giving guidelines for proctoring within our specialty. And this has, although Steve and I drafted it, this has been approved by the SCTS executive and also by BISMIX. And the real principle is patient safety first. That underlies the entire proctoring process. And it may well involve robotic surgery. That was my experience of it. But I think the principles apply whatever procedure you're developing. So the proctoring is there for teaching and tuition. More importantly, perhaps, for supervision. It's to provide a backup for patient safety. And also to provide sign-off for competence. And I believe any new procedure can have a number of stages, and they're not mutually exclusive, and they need not all be completed. But a good start would be some ex vivo training or an appropriate course. Cadaveric simulation, I found, was extremely helpful. It may not be available in the UK. And then observation of clinical cases. Yes, of course, if that's not available in your own unit or locally. The best option is if you have already selected a proctor to go and observe the proctor's team performing the cases, and you'll see any tips and tricks they may be able to offer, and also check out any pieces of equipment which may not be immediately obvious but would be helpful or critical when it comes to doing the cases themselves. Then you need to select early cases, and I think this is one of the most important areas. You need to select suitable cases in discussion with the proctor, who may well wish to review the imaging involved. And I recall when Mo Babra and I were starting our robotic program in Wolverhampton, we were mustard keen to get started. And that's always the time when there's a real shortage of suitable cases. But I think patience there is absolutely key. And then the proctored cases require full supervision, beginning to end. And importantly today, I think the patient needs to give informed consent for a proctored procedure. They're often very keen to have a novel procedure and hugely reassured by the presence of a proctor. There should be feedback after each case. And then after a suitable number of proctored cases, the proctor would hopefully be able to sign the team off to continue independently. In an ideal world, that proctor may then be happy to offer ongoing advice and mentorship to the team. So for the proctored cases, sorry this is repetitious, careful case selection, absolutely key. Proper consent. A pre-procedure review of the case is ideal between the local team and the proctor. And importantly, that should include a discussion of under which circumstances the proctor would intervene, or where we would convert to a more conventional access, if indeed minimal access is the type of innovation. Choosing a proctor is important. That person needs to have ample clinical experience of the procedure themselves. It would be an added advantage if you had someone with proctoring experience. They must be registered with the GMC and have a license to practice. And that's even if they are based overseas. I believe they require this in order to intervene if necessary. And for the same reasons, namely indemnity, the proctor needs to hold an honorary contract with the host institution. And these guidelines are very easily found. They're currently on the front page of the website. In case members find themselves on the other side of this equation, acting as a proctor, these are the duties that would seem appropriate. They need to ensure that the local team have suitable preparation and training. The proctor's there to provide supervision, but also guidance and support. Importantly, the proctor must be ready to intervene if patient safety is at stake. Advice for aftercare may be valuable. There are some complications which may not be seen in other areas of practice, such as, for instance, a single lung pulmonary edema from reperfusion. The proctor is required to give feedback and also, importantly, sign off, and may be happy to provide ongoing mentorship and support. We don't feel this is any longer the way you should learn a new procedure. So, yes, the SCTS, and I think all of us would agree, innovation is good. But governance requires supervision of any new procedures, and having a go isn't really good enough. I do hope the document is helpful. Thank you.
Thank you very much, Steve. That is very good to explain proctoring and also the differences with mentoring and how it could work. Do I have any questions? Anybody has comments? Anybody had experiences with proctoring that they want to share with us? Please do speak up. We just want to learn from each other. Yeah. So,
Mahmoud, Simon here.
Yes, Simon.
Well, there have been two great talks already since the break. So thanks, Shabiha and Steve. That was topic. And now you've put it all together like that. It looks so obvious, but sadly, surgeons have taken a long time to get their heads around how to introduce innovative practice safely. So it's really good to see this all put together. And I think the point you make is really important. The patient needs to be involved in what's going on because if anything does happen, I think it's just so wrong if they haven't been involved in a new technique, how it's being introduced, and the family should be aware too. So thank you very much.
Excellent.
Hey, may I ask a question as well?
Yes, please do.
Hi, it's Ramez. Regarding the consenting of a patient while you are doing a procedure under the guidance and proctor, how much information about your proctor would you share with the patient? I mean, the proctor details. A patient would definitely want to know who is performing the procedure, who is mentoring the performer of the procedure, and when would he intervene, what similar situation. I find it a little bit a difficult conversation because the patient might feel a little bit unsafe, even though that you might be trying to explain that safety is the priority, and that's the reason why the proctor is in there. So how much information would you share about the proctor? Am I allowed to share about the proctor with the patient?
Well, indeed, the proctor may wish to meet the patient, of course. My limited experience is that the patients actually found this quite reassuring. They were quite keen to have a novel procedure. They thought this was an excellent opportunity. And I think were very reassured that there was actually, although it was a new procedure in the hospital they were going to, somebody who did this every day was going to be present just in case there were difficulties. I think the patients have found this reassuring, and I think to undertake a novel procedure unsupported or with support that you're not acknowledging, I think that would be unacceptable.
That's excellent, Steve. Thanks. Rajesh, do you have a point or a question?
Yeah, Steve, thank you for giving a very comprehensive presentation on a complex area. As you're probably aware, Steve, SCTS is clearly very, very keen on supporting innovation across the country, really. And, having a document that you and Steve Woolley and yourself have produced is a step in that direction. And of course, SCTS developing the innovation committee is a step in that direction. My question is, how do you see SCTS developing a system to facilitate innovation through this committee? So what do you think SCTS committee should be doing to support innovation in terms of a system across the country?
Merely thinking aloud, Rajesh, I can imagine that it would be very useful to have a database, is probably a strong word for it, but a list of individuals with proctoring level experience in the various novel procedures which are spreading across our specialty. So there are robotic thoracic surgeons out there, the ones with a lot of experience who are happy to be proctors, they could be part of a list. Other novel procedures, reduced access cardiac surgery, surgical AF ablation even, which is not a very dangerous procedure, but is novel to many operators. That would be one way to facilitate, so that if one were looking to embark on a technique, the operator could approach SCTS rather than the company.
I agree with you, Steve, on that. When we discussed this document at the executive, this was one of the points I raised about vetting of the proctors and who is giving them the title of a proctor, and on which basis is it being decided, and who's assigning them. And it is industry who decides, isn't it? It's not us. I don't decide who is, or SCTS still, even with the document you produced, it does not give SCTS the vetting rights of proctors. And I think what you're suggesting is that SCTS goes down that route, maybe with the innovation committee having it as one of their items on their agenda of discussing a vetting procedure for proctors and then a registry of proctors. I don't know if that is, but that brings the responsibility to the SCTS, and I don't know if the SCTS would want to.
I wasn't quite suggesting that. I think a department looking to undertake a new procedure has responsibility to ensure that they recruit a suitable proctor.
I understand.
That it would be another step if SCTS wished to oversee and badge that. I don't know how the executive feel about that.
Narain, did you want to say something there?
Yes, I think the site's responsibility is to help create a culture where innovation is encouraged and supported, because I think a lot of people who have gone through a process of adopting a new technique have not necessarily felt supported in their own workplace because of pressures. The society's responsibility here is to make sure that innovation and new technologies can be adopted, but with the one simple principle of that patient safety, and the patient is the heart of anything that we introduce. So it's about creating an environment, a changing mindset that allows these things to be encouraged and supported, but making sure that patient safety is at the heart of that. And so not necessarily being responsible for proctoring that goes on in every department, but it's creating an infrastructure that can be adopted in different units for then different procedures to be brought on in a safe manner. So I think that's where the key is for the society.
Excellent. Thank you very much. Thanks, Steve, for a very interesting talk, and
thank you.
Highlighting the position of the SCTS on proctoring.